case tips and tricks in keratoplasty by Vishnu Teja.
Thank you, sir. Very good afternoon, everyone. I'm Dr. Vishnu. I'll be speaking on tips and tricks in keratoplasty. Slide. So I have no financial disclosure. Before proceeding, I would like to talk on the common difficult situations where we'll be encountering. Coming to the triple procedure in case of glaucoma, post glaucoma drainage devices, and in case of triple procedure in previous keratoplasty procedures, where we need pediatric keratoplasties and penetrating keratoplasties post herpes simplex virus keratitis, and in large diameter where we require large diameter corneal grafts like the PMD or keratoconus, and in keratoplasty in aphakia patients. So what are the common difficulties we'll be encountering? So all these, so I'll be discussing each in detail. So the inadequate akinesia or the positive vitreous pressure or the lens expulsion, so we need a very good anesthesia, so mixing hyaluronase to the block as well as a proper digital massage. And pre-operatively we also need a good control of the hypertension as well as the bronchial asthma to avoid the positive pressure. And also we need to control the IOP, especially in cases of secondary glaucoma, and also by giving pre-operatively IV mannitol. And keeping the patient's head position slightly up also will decrease the pressure. And speculum selection, as we all know, whenever we experience positive pressure, the first thing we adjust is the loosening the speculum. And vitreous tap, in cases where the pressure is too much, we can decrease the volume. And in cases we can employ the price graft or hose technique of suturing. And in where there is already expulsion, where we are encountering it, we need to do a finger tamponade and a temporary keratoprosthesis we can employ. And in cases of where we experience or we encounter vascularized corneas, we need to anticipate it before, so we need to control the ocular inflammation before to the extent possible by also giving topical brimonidine, and during the surgery by using wet field cautery of the dilated vessels, and some even tried the bevacizumab. And coming to the trephination technique, we need to keep the optical center making the limbus as a reference, and we can also use the radial keratotomy marker. And we also need to keep maintaining the pupillary axis as well as the illumination axis parallel, so that we need to keep the globe, we need to rotate it by holding it with the forceps, as well as adjusting the illumination arm parallel to the pupillary axis and perpendicular to the iris plane. And then during the trephination, we need to at least make more than 3/4 of the depth, and we need to do a slow decompression. And in case of perforated corneas, definitely we need to have a good facial block, and we need to avoid the digital massage. Flaring will be of very good help, and it also helps us to in adjusting the donor size as well. And in the perforated corneas, we have to avoid the trephination or putting pressure as much as possible. Manual excision will be more useful. Since endothelial loss is expected, we need to have a good endothelial count preoperatively, so having a good donor tissue is of importance. And of course, cohesive viscoelastic application to the endothelium, and employing and in cases where we experience very positive pressure, a modified price graft over hose technique will be also of useful. And in cases of flat grafts or where we encounter poor wound apposition, we may we can increase the size of the donor by a 0.75 to even 1 millimeters. And the IOL power, which we commonly encounter in cases of corneal scars where we can't have a good IOL biometry, so we can take the K reading or axial length of the other eyes, as well as we can also calculate the IOL power from the ipsilateral axial length and K of the other eye. And in large grafts like the keratoglobus or large PMD or advanced keratoconus, we definitely flaring a ring and a large peritomy, so that we can help, which can help us in suturing. And at least 1 millimeter larger graft is helpful in cases where we expect the open sky or the recipient opening is receding too much. and definitely we need to have a large number of sutures in these cases. And this is the modified price graft over host technique, which I will be showing in the video. So in this one, like the partial trephination will be done up to 80%, and the lamellar dissection where the debulking of the host tissue will be done, and then the remaining posterior stroma with the descemet endothelium will be cut quadrant wise, and then it will be immediately sutured, so that whenever we encounter the pressure we can take measures, as well as once the suturing is complete all the 360 degrees, then we'll liberally use the cohesive OVDs over it, and then we'll put the graft over it, and then after applying the cardinal sutures, like here I am applying the visco, and then sutures are applied over the graft to the host, and then we'll cut the remaining sutures. So the 4 sutures are there to secure it, and after this the prior what we applied the sutures will be cut, and then the posterior stroma tissue is removed from there, and then the routine keratoplasty is completed. So I will quickly rush through my slides. So these are the few cases after the keratoplasties, and my take clinic message will be like good anesthesia is always important. Preoperative measures to decrease IOP and slow decompression in high risk cases. Flaring yes, will be definitely useful, and use of modified price graft or host technique will be useful to avoid open scale complications, and that's all. Thank you very much. And I acknowledge Dr. MRD sir, Manoranjan Das sir for giving me some clinical pictures, and special thanks to AOS, APOS, Dr. Madhu sir and Gopal sir for giving me this opportunity. Thank you very much.
Very nice presentation, Dr. Vishnu. I just wanted to add a couple of points. Like you mentioned, for perforated corneas, it's essential to take very sharp, new, fresh trephines and go very slowly, so you're like slicing through butter. That is one point. And the other thing is, in case of routine keratoplasty is optical, where you're very you want to be sure of your visual outcomes, use suction trephines. They are now regularly available, and you have those with central Myers which help you to orient it. Always mark the center of the cornea before starting the case. It is very easy to do that either with the help of your dialer. Just bisect the cornea into 2 perpendicular to each other. Make sure that you have marked the optical center, and then mark it with the staining with the pen also. And then last is you have your RK markers. You can use them always for even if you are very senior and you've done thousands of cases. It really helps to get a very predictable outcome for your depth.
Thank you, ma'am.
Any other points from the other panelists? Now I request Dr. Dharmaveer Chaudhary to come and talk about Bowman lenticule transplant, all ulcers, one solution.
Good afternoon, everyone. I would first like to thanks the AIOS to give me a chance to speak on this special type of surgeries. In next 7 minutes, I will try to convince you that there is a gap between the ulcer treatments, and there is a gap between the standard of care in giving to these types of ulcers. I have no financial disclosures. Ocular surface, we all know, is a very special type of system which has a developmentally very diverse and originates from very diverse type of tissues and functionally integrated with the tear film, non-carotid stratified squamous corneal epithelium, limbus are being its parts. It has a very special immuno-neurohumoral arc which helps it in a healthy situation, and in disturbance of this arc one can result into non-healing ulcers. Corneal ulcers are a very heterogeneous type of group of diseases which can be like post-infectious, sicca, neurotrophic, immune-mediated, degenerative, traumatic, chemical injuries, etc. with their own set of challenges. And the treatments so forth developed are largely various types of lubricants, serum, the newer one therapies like these matrix, etc., recombinant nerve therapies which are so costly, bandage contact lenses, pad bandages, punctal plugs, botulinum toxin, etc. Surgical therapies are also very limited, and that too are not that too largely palliative like tarsorrhaphy, conjunctival flaps, amniotic membranes, transplants, banana graft also, etc. The concept of healing of these ulcers is to replace a very minimal amount of known diseased part with a healthy part, like a Bowman's membrane to be replaced by a Bowman's membrane, epithelium by epithelium, limbus by limbus, not to disturb the entire cornea. That is to deliver a point of care delivery, point of care therapy. So the goals of these ulcers are to cover the raw ulcer bed, to prevent tear imbibition and opacification, to reduce inflammation, infections and further ulcerations, and aid in epithelialization, promote rapid epithelialization and stable epithelialization. And desired covering materials, we all know, should be strong, transparent, natural inlays, or which can be later embodied into it. So we selected this part, that is Bowman's layer, and I will not go through the amniotic membrane, all of us are aware, and the time is very short. Bowman's layer, as we know, is the strongest, one of the strongest layer of the cornea, transparent, natural, innate structure that provides a very smooth surface to the epithelium to grow, grip, stay over. It stays over forever. It provides a micro environment to nerve plexus, which normal nerve plexus grows on into it, and epithelial cells to grow multi-layered, layer by layer, and it matures into the epithelium like with microplicata. It is also anti-vasculogenic, and it stops underlying inflammations, prevents tear imbibition, swelling, opacity, etc. So this is how we harvest this. We first mount this amniotic in this on this layer and on this artificial chamber, and we first remove this. This is removal of the epithelium, and then followed by trypan blue staining. It's not moving, friend.
So what is your technique, doctor, if you can tell us briefly?
Just a minute, yes, I think it's okay. So this is harvesting of the Bowman's membrane. And the epithelium is removed. So, and after removing complete epithelium, we can stain it with the trypan blue. We know that only this Bowman's membrane and Descemet's membranes are the only tissues which take stain. The rest of the stroma or epithelium does not take stain. So according to the need, we just mark it, refine only superficially. Then with the help of insulin syringe, we create an emphysema to separate, to let the stroma separate from the epithelium, so from the Bowman's membrane, the rest of the stroma. Let me speed up a little more. Then we cut it like this with a with a spatula, iris spatula. Okay, that's this one. This is the main concept. The concept is that this is a, you can see a non-healing corneal ulcer, a long-standing neuropathic ulcer, which is then measured, and a recess is created with the help of this crescent in the anterior stroma, largely anterior or mid stroma, so as to give a strong basement membrane inside it, without suture. Sutures are not required, no glue is required, just to tuck in this lenticule. This surface is very smooth, so the epithelium will, which naturally comes over this Bowman's. And after this tuck in, we put BCL over it. The surgery is over. Now, these are 4 or 5 more surgeries. Dermoid, you can see this is dermoid. We are removing it, creating another ulcer, cutting a small piece of lenticule and tucking in its place. And on the other side, you can see a corneal degeneration CDK with cataract. And on the lower side, you can see the lower fourth. There is a this was a case with the trauma repaired with a glue elsewhere. We removed that from the AC is collapsed. And we removed that glue and put this lenticule. The visions are generally 6966. We have done 12 cases, and one of my students has presented today this series also. These are some more ulcers you can see here. This is a PUK, small, a small lenticule can be cut and given a smooth surface. Here you can see a perforation and a non-healing ulcer, and this also same treatment, and it results in a very fine, very clean. Here in the lower side you can see a Salzman dystrophy with some vascularizations, and this also can be similarly done. Here again a glued, you can see the color of Bowman's layer here is yellow. Yellow is because it has been given a riboflavin dye, and a C3R has been done over it so as to strengthen it. This is one of the post-operative picture of this same patient. This is another patient. This is a PUK. These are the results of PUKs. This is the OCT pictures, day 1 to days 1 month on the 4th one. And post-operative regimes is very, very simple. All patients were prescribed topical moxifloxacin and a lubricant, as well as oral steroids or doxy, vitamin C, etc. And the patient followed up to about 6 months. We've done about 400 such cases, and we have done 1 PhD and PG, and we have been received an Indian patent too on the same technique. Some interesting experiences of this and the outcomes. This Bowman's membrane worked as a biological patching for the entire wound of any shape, thickness or size. This Bowman lenticule being very strong, largely consistent of collagen type 2 and 4, it stayed at this place. It was tucked in forever. That means it's unlike amniotic membrane, which dissolves in 2 weeks time. So it provides a long basement membrane for the for the epithelium to grow and mature, thereby giving a stable surface and contour. Being a true corneal layer for the very purpose as it naturally does, it allows the epithelial cells to grow, migrate, differentiate from basal to squamous cells, propagate and stabilize into layers. That it somehow controlled the inflammation, because it shut down the passage of the cytokines from up to below the in the wounds. It promotes nerve growth, and being largely acellular, it does not incite any foreign body reactions or hypersensitivity. So this therapy has some potentials. It has the potential to replace tectonic PKs in many cases. It has the potential to replace cyanoacrylate glue treatment for all perforations. It has the potential to replace present surgical treatment of PUKs. It has the potential to modify, simplify surgical steps and outcomes in the symblepharons, dermoids, etc. And of course, it can be used as keratoconus. Future applications also, being a strong collagen, it can be used in scleral thinning also for time being. It can be used in scleral perforations, blab leakages. After all, it is purely collagen. It can be used as only on keratoconus. Just remove the epithelium, put over it, and forget it. Summary: the existing surgical approaches are largely palliative. Bowman's membrane treatment is a point of care treatment. The outcome of this procedure in terms of wound healing, wound strength, contour, visual recoveries, amelioration of symptoms, and cost effectivity are very exciting. Surgery per se is simple, quite simple, short, smaller learning curve, less invasive, less painful, less traumatic, less suture, and less steroid related complications. No great instruments are required, no resources are required, no corneal tissues were, because tissues were all therapeutic grade. So it's a win-win situation. The easiness of surgery, short patient stay, short postoperative and smaller regimes and periods. So it's patient friendly too. And so our preliminary results are highly encouraging, and this study of ours will pave way for all types of non-healing ulcers. Thank you so much.
Nice, innovative presentation. I have one question. When
Yes.
there is a perforation,
Yes, sir.
is the dissection or pocket making is not a difficult thing?
Not at all, sir.
When there is a perforation,
If the perforation, we have done it in perforation less than 2 mm.
small perforation.
Small perforations.
So in that you are replacing only the anterior layers. What about the posterior? Will not cause a later on ectasia like that?
Well, the perforation part is very small, but the thinning part is long. So suppose if it is 2 mm, the thinning part is more than 4 mm, and the granulation tissues are there on that part. So the granulation tissue will be fibrotic and stronger. So we have not found any this type of what do you say
Ectasia.
activities are not found.
So interesting
Congratulations.
presentation. I have a question. What's the mean thickness of the Bowman lenticule that you have harvested? You have done ASOCTs
Well, that is around 40 mm.
around 40
40
microns.
because about 50 to 20 mm is the normal thickness of the ulna, because we take elderly donors only after 65 75, which are therapeutic grade. So they are thickened ones, they are stronger one as well, but there are some stromal fibers too. On biopsy also we have shown there are some stromal fibers. So it is around 40.
Congratulations, it's a wonderful procedure. I think in cases of neurotrophic melts also it makes
Yes,
a lot
sir.
of sense.
Yes, ma'am,
And
very much.
any cases of interface haze or infiltrates?
Not particularly due to surgery, or not particularly due to something like not procedure related, but as a infective part. But yes, one more thing, in cases where where we have done in post infected cases, there was a hypopion for some days which was gone after some treatment.
You are saying that you are using it for small perforation. Why can't we use it for large perforation like 3-4 mm and take infinity suture like we took in AMG? If it is a thick, you are saying it will support. Put over a 3 mm perforation and take 2 infinity suture, I think it will support.
But the thickness is only, as I said, very thin. It may cause a
If it is thick and you put 2 infinity suture, the apex of infinity suture is passing through the perforation, it will not have ectasia. If the 2 apex are passing
think
over
it
the
can
site
be
of
explored.
perforation, it will not have ectasia.
It will cause a tent like.
It heals. It heals like in AMG also, it heals hair also. We can try.
Thank you.
We invite Dr. Rohit Dureja for his talk on management of post-penetrating keratoplasty astigmatism, a case-based discussion.
In keratoconus, we are using as an overlay. We have just started, not done it. Not in them.
I think, madam, what you are referring to is Bowman's layer transplant. Yes, this is a different technique. He's using it for perforations and desmatoseals.
It was just an indication. Yeah, but no, that was not keratoconus. That was Salzman degeneration.
Use the cross-linked cornea.
Okay, so very good afternoon to all. Firstly, thanks to the AIOS Scientific Committee for providing me this opportunity. Rohit. So the aim of the keratoplasty is not just achieving a anatomical outcome, good anatomical outcome in terms of a clear graft. We have to achieve a good functional outcome also in terms of a good vision. Now, no financial disclosures. So despite if you have a clear corneal graft, patient is not able to see, that means the functional outcome is not achieved. And why it is not achieved? Because of astigmatism. So 15 to 20% of the patients post keratoplasty, they have more than 5 diopter of astigmatism. Now we'll see how to tackle it with the help of some case-based discussion. So how you deal with the post PK astigmatism? If you have suture in place, then you have two options. You can do suture adjustment if you have taken a continuous suture. What if you have taken all interrupted sutures? Then you have to do the selective suture removal, which starts usually after 3 months. If you don't have any sutures, all sutures has been out usually after 1 year or 2 years, then there are two methods, which is the non-surgical method and the surgical methods. If there is graft with no suture, the non-surgical method is that you have the spectacles, otherwise the contact lens, RGP lens, scleral contact lens, we have types of varieties. And in the surgical methods, there are only two types. One is the corneal based or the lens based. In the corneal based, in the past we have used the AK, the extremity keratotomy, or the relaxing incision compression suture, which is known as RICS, or you can do the surface ablation like PRK. And the last resort is you repeat the keratoplasty. And the lens based, we have customized toric IOL or the phakic IOL. So this is a case of a 73-year-old male. He underwent PK in the right eye 3 months ago. So usually the suture removal we start at 3 months. And this is the topography. You can see there is a steep axis, which is the red color in the at 5 o'clock area, and another steep axis, the steep hemimeridian in the 10 o'clock area. So if you want to remove the sutures, you can remove two sutures in the at 5 o'clock area and the 10 o'clock area to tackle the astigmatism. So in this topography, as you can see, there is a 7.72 amount of astigmatism, and when you want to tackle it, you can start the suture removal at 3 months by removing two sutures at each semi-hemimeridian. So this concept was given by Cottingham in 1980. What we do it, we remove the sutures in the steep hemimeridian and the corresponding steep hemimeridian. After suture removal, it will become flattened. So how to do it? So you do refraction in the OPD, you do keratometry, you do topography. They are the useful tools which will help in guiding which suture you will remove. But sometimes if all these three things are not correlating, then the topography is the best method, superior to refraction and the keratometry. But if the topography, refraction and your keratometry, if they are coinciding, so the effect of suture removal will be maximum. If they are not coinciding, the effect will be variable. Now, how will you remove the suture in a keratoplastic graft? So there are two principles. First principle is that the node should not traverse the graft host junction. Why? If it traverses, it can lead to graft host junction desiccants. Second principle, the exposed part should not go inside. The epithelium, the part which is outside, that part of the suture should not go inside. So in this picture, if you see, the knot is on the donor side and this is the host part. So this is the knot. If you want this knot doesn't cross this the graft host junction, it has to come out from here. And the second principle is that the exposed part should not go inside. So if you want that this exposed part does not go inside, so you have to cut it here. So you cut it here and pull it straight. So this way the exposed part will not go inside and the knot will not cross the graft host junction. Timing of suture removal, if you remove the sutures within the 1 year, it will have some effect on astigmatism. After 1 year, there are it is the study. There are various studies which shows that some has effect, some studies shows that there is no effect after if you do suture removal after 1 year. Another case, 25-year-old male student. She underwent left eye PK for the corneal scar in 2020. This is the post PK post keratoplasty picture. If you see the left eye after 3 months, the vision is 20/20 and the astigmatism is -1. 6 months 2020, astigmatism is only -1. Out of 16, 2 sutures have become loose, so 2 sutures were removed. 14 sutures are still intact. 24 months, vision is 20/20, astigmatism is 0.75. What will you do? You observe. Either now there is two things. If it has crossed the 1 year, you can try suture removal alternatively, but if it is before 1 year, you have to wait, because if you remove the suture in this patient, there can be a variation in the astigmatism. But if it is after 1 year has been crossed, then you can try by alternate suture removal in multiple visits. Another case, which is a 53-year-old male farmer. He presented to us with a blurred vision in the right eye. He has undergone DALK in 2012 for HSV scar. So this is a refraction, 2200 vision with the -6 cylinder. So he is a farmer, the graft is clear, there is no sutures, there is early cataract. And this is the topography, which is showing the about 10 diopter of astigmatism with the rule. So what will you do? So in this patient, since he is a farmer and he is having early cataract changes, we did phacoemulsification with the relaxing incision with the compression sutures. We tried, because he was not he doesn't want to undergo like costly procedures like PRK or the customized toric oil. So in this patient, we did the minimum cost procedure, that is phaco with and the relaxing incision and the compression suture. So how you do this relaxing incision and compression suture? So relaxing incision are put on the steep axis, compression suture are taken on the flattened axis. So in the topography we saw, it is vertically steepen. So we will do 2 relaxing incision over the vertical meridian and 2 compression suture over the flattened axis. But what happens that after the surgery, there is a return of astigmatism. Now it is showing the post of 9 month 8 diopter of astigmatism. Now what will you do? There are only two options: contact lens or repeat the graft. Next case is a 34-year-old male who are presented with the blurred vision in the left eye. She underwent triple surgery. Best rated visual acuity is 20/50 with -6 of cylinder and -11 of spherical power. So clear graft with the PCIOL. And this is the topography. So what are the options? You can do contact lens trial, you can do RICS, you can do surface ablation, but dealing with a -11 of spherical error and a -6 of cylindrical error will not be possible with the PRK. But you can do with under correction. Fourth option is lens-based procedure. Already he is a PCIL. You can do IL exchange, but it will be difficult, but a long time. Capsule will be fibrosed, or you can put piggyback IOL or the phakic IOL, or the last option is the repeat graft. So PRK was planned with under correction. The initial before surgery it was -11, -6. We targeted for -4, and the residual was -7 to -2. And this is 1 month after PRK. Vision is 20/30 with minimum cylinder of -1.5 and -4.5 of spherical power. Last case, 63-year-old, diminution of vision in the left eye, started post PK in 2008 for Fuchs. Vision is 20/60 with -8. Clear graft, 1 broken suture, some cataract changes. And this is the topography, fairly regular topography. So what are the options? The contact lens, RICS, surface ablation, lens-based procedure, or repeat graft. So in this patient, we underwent with the lens-based procedure. We put phacoemulsification with the customized toric oil from the care group. And the post-operative vision was 20/20 with -1.5 of cylinder. So just to summarize, graft with no suture, non-surgical methods are spectacles or contact lens. If you want to do surgery, the corneal based are RICS, but they are very unpredictable. You can do surface ablation, you can do the last resort is repeat keratoplasty, and the lens based procedure are customized toric IOL or the phakic IOLs. Thank you.
Very nice tips, doctor. So what is your go-to procedure for post-refractive? Say 1 year post cornea transplant, what would be the first option that you suggest? No cataract?
To treat the astigmatism. It depends upon the age. If there is no cataract, we can try. First thing is contact lens. RICS, AKs are very unpredictable. Your results are very unpredictable. So only option we have left is PRK. If there is no cataract, if there is a cataract, customized toric IOL with the care group, they can customize with any amount of astigmatism.
Dr. Revati from Coimbatore has described her procedure of wedge resection, in which she bases the wedge on the topographic appearance of the, and she has very good repeatable results. Although I have no experience myself, I just wanted to add that. We call upon the next speaker, Dr. Tripura, dilemmas in deciding refractive procedures. All speakers are requested to stick to the timing.
On the on-site, I thank AIOS and APOS for giving me this opportunity. Today, I am Dr. Tripura Velapudi, working as a consultant at CFS Vijayawada. Today, I am going to talk about dilemmas in refractive surgery. So, the goal of the refractive surgery is to reduce the dependence on contact lenses or glasses for use of routine daily activities. A wide variety of surgical techniques and technologies are available. All require an appropriate preoperative evaluation to determine the best technique and ensure the optimal outcome for each patient individually. So as we all know, the refractive surgeries can be broadly classified into corneal-based procedures, lenticular procedures, and combined procedures. The corneal-based procedures most commonly used are trans-PRK, femtoLASIK, and SMILE. Lenticular procedures are phakic IOLs and a clear lens exchange. Selecting the right procedure for the right patient is the most important in refractive surgery. It depends upon the availability of equipment, surgeon preferences, patient parameters, and indications. So we all face dilemmas in our routine day-to-day practice. So I take you through 3 to 4 cases which we have gone through in our OPD, and we have decided to do a refractive surgery for those patients. Coming to my first patient, a 31-year-old male came to the OPD with a cylindrical power of minus 3.5 diopters at 30 degrees in the right eye and minus 4 diopters cylinder at 170 degrees in the left eye. Keratometry is absolutely okay, and the corneal thickness is 496 in the right eye and 504 in the left eye. The best corrected visual acuity of the patient is 6.9. Coming to the pentacam pictures of in the right eye, it is normal. It has no red flag signs as such, and the Belen also is normal. So in spite of being a cylindrical power, we have gone ahead and done a trans-PRK for this patient and application of mitomycin C, and postoperatively patient got a best corrected visual acuity of uncorrected visual acuity of 6/9. As we all know, there is no flap interface complications in case of PRK, and there will be very good biomechanics as we are not disturbing as such, and it is a minimally invasive procedure. The patient discomfort is always there, but we have tackled it to the maximum extent by using an NSAID dip BCL or an cold BACL. The risk of haze is usually present in PRK cases, but still it depends upon the body healing status of the patient rather than the powers. So coming to my second case scenario, a 23-year-old female came to the OPD with a refraction of minus 4 diopters spherical in the right eye and minus 3.5 diopters spherical and 0.75 diopters cylinder at 180 degrees in the left eye. Coming to the keratometry readings, it has a steep corneas in both the eyes, and corneal thickness is 514 and 515 in both the eyes respectively. So these are the pentacam pictures in the right eye, which is absolutely normal. In the left eye, in the right eye, Belen also is normal, which doesn't show any difference in maps. So, but in the left eye, there was an anterior float disturbance, for which we have asked the patient for a contact lens history, and we have put the treatment with lubricating drops for the patient for 2 weeks, and then repeated this scan again, and then gone ahead and done a femtoLASIK for this patient. The LASIK offers us the full range of treatment for myopia, astigmatism, and hyperopia. It has very faster recovery, and we are doing from so many decades, and LASIK is really promising results. So as we should remember in our mind about the flap complications which can occur in very flat corneas and steep corneas, and the incidence of dry eye is much more than compared to other procedures, and it has the weakest biomechanics compared to the other refractive surgeries which are present in our armamentarium. The SMILE indications are same as that of a femtoLASIK, except that it doesn't correct hyperopia and astigmatism. It is better biomechanical stability because it preserves the Bowman's and the anterior stroma, and it causes less dry eye incidence. This is my third case scenario of 25-year-old male came to the OPD with a refraction of minus 14 diopters spherical and minus 2.5 diopters cylinder at 10 degrees in the right eye, minus 15 diopters spherical and minus 2 diopters cylinder at 170 degrees in the left eye. Keratometry is normal and corneal thickness is 562 and 553 in both the eyes respectively. The ACD is 2.8 in the right eye and 2.79, which is internal ACD, which we take in cases of phakic IOLs. And the best corrected visual acuity is 6.9 in both the eyes. So we have gone ahead and done a gonioscopy for the patient, and we have found it as an open angles. In spite being a borderline ACD, we have gone ahead and done a phakic toric IOLs in both the eyes, and the patient got an uncorrected visual acuity of 6/6. Usually when we put phakic IOLs inside the eye, as it is nearer to the nodal point, the patient will have an uncorrected visual acuity better than the best corrected visual acuity preoperatively. This is the same, and this is my last case. This is my last case in which a female patient came to the OPD of 26 years old with a refraction of -20 diopter spherical and -3 diopter cylinder at 15 degrees, and -16 diopter spherical and -1 diopter cylinder at 130 degrees in the left eye. The keratometry is absolutely normal, and the corneal thickness is 497 in the right eye and 492 in the left eye. The best corrected visual acuity in the right eye is 6/60, and in the left eye it is 6/9. Because there is an anisometropia in the right eye, the patient had only best corrected visual acuity in the right eye of around 6/60. So we have advised the patient to use a contact lens, but the patient is really keen in getting a refractive surgery done. So we have gone ahead and done a refractive lens exchange and implanted a trifocal lens inside the eye, and the patient is really happy and got a best corrected visual acuity in the right eye of 6/24 unaided. So these are the pentacam pictures of the same. Coming to my last slide, no one modality is perfect for every situation. Understanding each patient's need is critical. All modalities have a place in refractive surgery armamentarium, so we have to take into consideration the patient needs, the occupation of the patient, and the patient expectations. The patient expectations plays a very important role in refractive surgery, and SMILE is gaining on LASIK as it has better biomechanical stability and less dry eye. Once we get a SMILE for hyperopic correction and astigmatic correction, I'm sure all of us will go ahead and do SMILE for all our cases except a borderline corneas, which we go ahead and do a PR case. Phakic IOLs and RLE give promising results, but it is mandatory to get a pre-operative evaluation by a retinal consultant, because every time it is an intraocular procedure, and at any given point of time we have a risk of getting any retinal complications. Thank you so much for your patient listening. Thank you, sir.
Variety of cases. Only my question is, you have one myopic patient, last but one.
Yes,
You
sir.
said not improving 6/60, but
Yes, sir.
improved with multifocal. One is that. What
Yes,
about
sir.
the retinal examination and OCT and the FFA?
FFA we didn't do it, sir, but the retinal examination was absolutely normal, sir.
Normal
a
means
myopic
I
fundus.
won't agree with amblyopia when one eye is 16, another eye is 20.
It
They
has a
won't go
high-
into amblyopia. If it is only unilateral, it will go. High myopes, they will have a very good vision. There is no question of amblyopia. Definitely there is a problem in the thing. The other thing is doing a clear lens extraction in high myopes. Be careful. Be careful. Unless you are a retinal surgeon, don't touch it. Whatever complaint he gives, you have to examine the retina. Floaters, sir, yes. Flashes, sir, yes. There is a slight decrease of vision, sir, yes. For all the time, this high myopes, you have to screen. You believe me or not, one-eyed patient, we operated, and post-operatively 6 years after, he came with floaters. I refer immediately to retina. Retina says retina is on, no treatable lesions. 1 week after, he landed with RD. That means whether I have to blame the patient or the retinal surgeon. Within 1 week, he landed in RD. That means if he is a high myope, daring the removal of the clear lens, be careful. Thank you.
Thank you so much, sir. PR, please, sir.
That is not a proven treatment. That is not a proven treatment. Unnecessarily burning the retina all around.
You call upon.
TTL sir, what about your opinion? Removing a clear lens in high myopes and putting a multifocal lens.
This is actually not really warranted for all cases, but there are some situations where patients are very, very adamant you may be forced to do these surgeries. But as rightly sir pointed out, you have to do a good examination of these patients and always highlight the important risk factor for patient, the important signs and symptoms by which as the patient came back with the floaters. So we have to be very careful examining these patients also. And sometimes they have such a high myopes where multifocal may not be available in that power also. There again you may have to only go for a monofocal lens and give a near vision for these patients also. But if patients are good with a contact lens, high myopes, they can still manage. Unless there's some sort of nuclear sclerosis coming up, you do if you have access to eye trace, you can do a DLI and see if the DLI is very poor, less than 5. You may be justified to do a surgery in those patients with the explained prognosis. If the lens is clear, patient's all right, maybe you can avoid surgery for, because we know that chances of detachment increases 8-folds if you do surgery in these cases. You have to be much more careful. One case shown by her was, post-contact lens he talked about. If you see the topography of patient where you see there's a anterior float is steeper, it can be keratoconus also. But see that other parameters are normal, your D value is normal. Suspect there may be some epithelial problems. There may be epithelial thickening happening in these cases. You always do anti-segment OCT, do a epithelial mapping in these cases. If your epithelial mapping, the thickness matches with the steepness, that's some sort of warpage happen with the keratoconus. Normally in the keratoconus, there will be thinning of epithelium with the same area of ectasia, that is keratoconus. If the epithelium is thickened up, that is causing the anterior float increase, that's some sort of a ocular surface problem or a contact lens related problem. That's the way you identify that.
Yeah.
Dr. Madhavi?
Yes, I'm here, sir. I'm ready here. Good afternoon, everyone. I thank the organizers for giving me this opportunity. So my topic is PRK revisited. Why do I say so? Once radial keratotomy went into disrepute in the 1980s, PRK had its initial period of glory, but then there were the limiting factors in the form of vision-threatening haze, inconsistent and unpredictable outcomes, the regression and the pain. In that time, LASIK emerged as a clear winner in the late 1990s in the terms of safety and rapid recovery, predictability and reproducibility. Both doctors and the patients had the wow factor and they liked it so much, and it was a very popular procedure. However, slowly the bugbears started showing up in the form of microkeratome related complications, a rare occurrence of DLK, and better understanding of the corneal wound remodeling and the biomechanics. We also came to get more awareness regarding the possible post-LASIK ectasia. Femto-LASIK as well as SMILE offered a higher safety profile and less dry eye concerns. However, post-LASIK and post-SMILE ectasia also have been reported. And we also need to keep in mind the availability of these two technologies, expertise to perform them, and also the cost factor. So coming back to what causes ectasia, we don't know whether it's the corneal biomechanics, the genetics, or the hormonal level changes in pregnancy, or it could be something as simple as eye rubbing. Whatever it may be, it was found to be the least with PRK. So all these factors led to the resurgence, rejuvenation, and resurfacing of PRK. So what are the advantages over LASIK is that it conserves the corneal tissue, so it's ideal in a thin cornea. There are no flap related issues, so it's safe in steep and flat cornea. In large mesopic pupil diameter, it's feasible to plan large optic zone treatment. Biomechanical response is more predictable. Wavefront ablation also is better response with PRK, and recovery from dry eye also is better with PRK. So coming to the indications, 18 years and above with a stable refraction of more than 6 months to 1 year. The refractive range would be less than -8. Of course, some people do up to 10, 12 also, but I usually restrict myself to -8. Hyperopia of 4 and astigmatism of 4. And we need to, one more plus point we need to remember is on most of the redo procedures, PRK is the procedure of choice. And whenever we have a complication encountered in any other form of refractive surgery, PRK is the go-to procedure, either on the same day or at a later date. And in case of a suspicious cornea, even with a small error, PRK can be performed with good results well within the safety parameters. Coming to the contraindication is the pregnancy lactation, unstable refraction, corneal ectatic conditions, advanced keratoconjunctivitis sicca, tendency towards keloid formation, herpetic infections, and connective tissue disorders. So coming to the technique, we have the PRK, LASIK, EpiLASIK, and trans-PRK, of which the PRK and the trans-PRK are the most popular. Each of them have the same excimer laser application, but wherein we remove the epithelium has a different way of modality of removing the epithelium. So coming to the PRK, it's the epithelial scraping which is done either manually or with laser, that is the trans-PRK. The epithelium is completely removed, permanently removed, and then a BCL is applied on the bare stroma after the ablation. New epithelial cells are allowed to regenerate. In the trans-PRK, initially the stroma is ablated followed by a epithelial removal, all in a single smooth continuous step. This was first implemented on the MRS Excimer platform, Schwind iTech Solutions. So it has a popular tagline, no touch, single step, all laser solution. Patients are much happy with that. Though it's a PRK, they say, okay, there's no mechanical debridement, so they prefer that. And the faster epithelial recovery could be due to the smaller and a neater epithelial edge, which translates to less pain and less discomfort from the patient point of view. Does it work? Yeah, here. Okay, yeah. So you can see here that first you're going to, this is the trans-PRK. I want the next slide. Just a moment, please. Yeah. So here you can see that after anesthetizing the cornea with the proparacaine and the speculum is applied, drying of the cornea is very important because wet cornea you're going to get a lesser response. And with the Schwind platform, we have most of the platforms have that. There's the eye tracking which is done, so that the iris recognition is done. And after that, you have to dry the cornea. Sorry, there's some problem. Okay, dry it properly, and then you can see that when you apply the laser, yeah, it's all in a single step. There's no mechanical debridement here. This is the trans-PRK. And going back to the previous one, what you will be doing is you have to mechanically remove it. It's not very difficult, but patients sometimes they are not very cooperative. So you are going to make a epithelial marking as to how big your the circle should be. You can do it by yourself. It's a circular marking that you want. You'll slowly debride and make it smooth. See that, take care that there's no island. There should be no epithelial island remaining because that area would not be ablated otherwise. Patient cooperation is important, but not a big issue because patients are, most of the treatment in trans-PRK is over within a minute before you can even realize. And here it take a little longer in case of the classical debriding the epithelium manually. So coming to the concerns, though both of them give excellent results, there are two concerns that we need to address to. One is the haze, which is not very frequent nowadays. What would that be because of? Usually the low to moderate powers only are treated. Though that's what I was mentioning. Up to 10, though they say it's better to go for low to moderate powers. And the newer machines have smoother ablation profiles. And also we use mitomycin judiciously in a titrated dose. Coming to the pain, even this is managed very well using chilled BSS, BCLs. BCL is a bandage contact lens which is soaked in NSAID drops. That is controversial. Some people prefer it, some people don't. And also chilled BCL. So the take home message is a good refractive procedure is one which is easily accessible. Moderately skilled surgeon should be able to perform with a shorter learning curve, which should give optimum and reproducible results with a good safety profile, and it should be financially viable. So though PRK may lack the wow factor of LASIK, it still scores against the risk of ectasia, flap-related complication, and induced higher order abrasions. And I would say it's here to stay. Thank you for your patient listening.
Nice presentation. It is a true. We are coming back to the PRK. Our keratomes are lying ideal. How long you keep post-operative steroids?
Steroids. First, most of the time I use only fluoromethalone, FML. I keep it on a tapering dose, QID for a month, and then seeing the response, I either taper it on 2 weeks or a monthly basis, and also depending upon the power. If it's a slightly higher power, then I keep it for a longer duration. Otherwise, within 3 months, I remove the steroids.
See, the haze is proportional to the power. If you ablate more power, more chances of haze. In those cases, you have to prolong your steroids. But not common, rarely. In my experience, I have seen 5-6 cases going into frank glaucoma.
Yes.
What the explanation the glaucoma people say is, he is a highly steroid responder. Steroid responders are 3 types or 4 types. high responders, medium responders, low responders, no responders. So like that, this particular patient is high responder, that's why he is dead. So if I stop the steroid, he gets the haze. If I start the steroids, he will get glaucoma. So a demanding patient, if you want very cautious, high myope like -8, she says, you give in one eye a trial of steroid for 1 week to 10 days before treatment. If there is response, don't touch that eye.
What I usually do, sir, is when they come back on a post-operative follow-up, once we remove the BCL, we anyway do a non-contact tonometry. So if I see if it's on a slightly
Every visit
higher,
we do.
yes.
But if it is a raised, what will you do?
Immediately start them on, because there will be a myopic shift also, so we have
If
to
you
start
stop
them.
it, haze.
No. Along with that, I give a topical anti-glaucoma medication as well.
That is temporary. But parallelly, you are giving steroid, which is causing a permanent glaucoma.
I have not come across that, sir. Usually
I come across 5. The last case I have seen is a B.Tech student done elsewhere, referred for marked haze, and it resulted in one line vision, 6/60. Be careful about it in high myopes.
Was it related to the haze or because of the IOP, sir?
Haze.
Yes. Okay.
Marked haze like a disc in the center.
Yes.
Why that local doctor stopped is because of the afraid of glaucoma. The highest pressure he recorded is 38. He referred to glaucoma. Glaucoma man asked stop, wrote in black and white, stop steroid. Isn't it? So what is the fate of that B.Tech student? Isn't it? But in high myopia, see, for example, when we started, it is 4. Beyond 4, no PRK. Then 6, then 7, then 8, then 11. You have to cut at one stage, keeping in mind high myopes, where we have to use longer time steroids for a longer, higher abrasion. In one line, comment, sir. In one line.
No, as far as I'm concerned, I don't do PRK that much at all because of 2 reasons. Nicely highlighted, haze coming up some patient. Sometimes the regression is much more in a PRK than other procedures, and we have a option of doing a LASIK or a SMILE in such cases. And PRK requires a little but much more modulation of your patient. Post-op treatment is longer. Sometimes pain is much more. Yes, it is easier and much faster surgery. But if possible, I'm not sure if people are doing PRK, but you have to have a better system, better understanding, and better this thing. And haze is possible in most cases. Even a 1 diopter PRK can have a haze also. There are different people, they have more haze. And the steroid responder is a fact in all cases. We do have patients. And starting non-steroidal anti-inflammatory drug is also controversial in these cases.
Yes.
Sometimes cornea can melt also in some situations.
Yes.
So you have to be very, very careful in these group of cases.
So take the history of keloids also.
Yes.
Even sir, IOP measurement could be wrong because you have done -8, 100 mm you have removed, and you are taking the IOP measurement. You are not correlating the thickness because you 100 you have removed and you are measuring it 15, which it will be 25.
Translate.
No,
Translates.
we always think the correct time.
For general population.
We call upon the next speaker, Dr. Saili Tamankar, for post-LASIK flaps try. Quick comment before as she sets up. So I think for the youngsters who are just starting off PRK, just a single drop of NSAID before putting the BCL helps in tackling the pain. Also stick to the instruments that are given in fellowship. Maybe you're given anything by the staff. So a hockey stick really helps to take off the epithelium safely, or using a well really helps in maintaining that contact time of this thing. So stick to the instruments, they are very important in the learning phase at least.
Pole doesn't touch the conjunctiva, the pain will not be.
So good evening everybody. So I think next few topics we are going to now discuss few complications of LASIK. So thank you for giving me this chance to speak here. So a optically clear, smooth flap is absolutely essential for a good outcome in LASIK. But when there is any irregularity with the flap of the LASIK, and especially the flap striae, it is sure to bring frown on a surgeon's face. So it is one of the most common LASIK flap related complications. It is nothing but few wrinkles or folds in the LASIK flap. Various studies have reported an incidence of around 1.1 to 3.5%. So based on the size of the striae and the involvement of the thickness, they have been broadly classified as macro striae, which are full thickness in the flap folds. They are seen as parallel lines, which look like windswept sand and washboard. They are usually cause visual blurring, and they are visually significant. The other type of striae are micro striae, which are usually superficial in location. They are usually seen as random pattern of fine irregular lines, like a dried cracked mud. They rarely cause visual symptoms. So what are the etiologies where we get LASIK flaps? Starting with the intraoperative factors: very thin flaps, high myopic ablations, desiccation of flap during surgery, or excessive asymmetric hydration of the flap, excessive manipulation or stroking movements which are done during the surgery, the flap misalignment or poor adhesion of the flap over the stromal bed can lead to LASIK flap folds. Also, inadvertent LASIK flap folds can happen when a lid speculum or drape is removed in a more irregular way. So in post-operative factors, when most of the cases present in early post-operative period, it can be because of eye rubbing, eye drop bottle tip touching the eye, long naps, when the patient doesn't use lubricant eye drops for a long time, when the patients excessively squeeze their eyes, and because of trauma. In late post-operative period, usually trauma is the cause. So what are the clinical features of LASIK flap folds? Usually patients present with blurred vision, glare, halos, shadowing. They are because of induced irregular astigmatism and ocular aberrations. They also can present with sudden onset unusual pain due to traction on the dislocated flap due to excessive drying. There can be a history of eye rubbing, also trauma to the eye. They are usually commonly seen in early postoperative period. So a very careful slit lamp examination is required to find these very subtle findings. If you see in the first picture, there are very fine parallel lines which are seen in the supero-nasal quadrant of the eye, which are becoming more prominent when we narrow the slit. If we stain this eye surface with fluorescein, then these lines become very well seen. Also, we can see that when there is a flap dislocation or slippage, there will be an accumulation of fluorescein stain in the stromal bed, along with the accumulation of stain in the striae. We should always see the eye again after pupillary dilatation, because the pupillary dilatation makes it very easy to delineate the striae, and we also know the extent and configuration of the striae. ASOCT will help us to see whether there is any epithelial hyperplasia which has happened. Also in this picture we can see a hyperreflective layer which is epithelial ingrowth. So what all we can do to prevent flap folds from happening? So pre-operatively we should take care that the dry eye has been adequately treated. We should avoid desiccation and excessive hydration of the flap during surgery. Avoid excessive manipulations. We should give adequate amount of time for the flap to adhere. Careful removal of speculum and drape is required. Post-surgery, frequent lubrication is required, and a prolonged nap should not be allowed. Patient should be asked to wake up at least after 1 or 2 hours and put their lubricant drop and may take rest again. Protective glasses and no eye rubbing has to be ensured. So when the flap striae are visually significant, central, multiple, so they need early surgical intervention. So what are the surgical techniques which are employed? If a patient has presented very early, like within few hours of visual blur, then only flap lifting, hydration of the flap and stretching of the striae may suffice. Removal of epithelium from the stromal bed and some area beyond the flap edge is required, but we can spare the epithelium over the flap surface. And then we can reposition the flap and BCL can be applied. Hydration is mainly done to swell up the flap and so mainly we are aiming to swell up the anterior surface of the flap so that the striae stretch and resolve. It is done with a hypotonic solution like distilled water that stretches and smoothens the striae. Excessive hydration of the posterior side of the flap should be avoided because anteroposterior swelling can cause contraction of the flap diameter, and again it can induce misalignment of flap on the stromal bed. So stretching maneuver has to be done in a direction perpendicular to the direction of the striae. It can be done with forceps and also can be done using 2 dry Merocil surgical sponges. So suturing is recommended when the striae are not getting corrected with these maneuvers. So this particular case had presented very early, just within couple of hours of the trauma. So we had just done irrigation and hydration of the flap with distilled water, and then epithelium was removed just to clear the area beyond the edge of the flap. Then the stretching was done using dry Merocil sponges. Again, smoothing was done using an irrigating cannula. And when we saw that the striae had significantly reduced, then we had concluded the surgery. So here we have to note that the striae may not completely get resolved at the end of surgery, but if they are looking significantly lesser in number, then we can conclude. And the same patient after day 7 is showing no striae and a completely clear flap. So for few other surgical techniques, when the patient presents late in the late presentation, then flap striae tend to become more and more fixed because of the anchoring effect of the epithelium, which leads to contraction of the stroma. So here additionally we have to do de-epithelialization procedure to release the anchoring effect of the epithelium over the striae, so that can allow smoothing of the striae. So this is the surgical video where we have done alcohol assisted epithelial removal, and following which some more epithelium from beyond the edge of the flap was also removed to avoid ingrowth in future. Then the flap was hydrated with distilled water, and it was lifted. Then under surface of the flap was also irrigated, and multiple times hydration was continued, and with stretching of the stretching maneuvers of the striae, they were removed. So when the at the conclusion of the surgery, it was ensured that the flap has been given adequate time to adhere, and then a BCL was applied. So other few treatments which have been described are hypothermic treatment, where a special spatula is heated in water at 65 degrees Celsius and used to smoothen the striae using little more temperature. When the striae are recalcitrant, phototherapeutic keratectomy may have to be used. A transepithelial ablation is used, followed by second phase of medium ablation using a masking agent. So I'll skip this. Few complications after getting a flap striae can be epithelial ingrowth, diffuse lamellar keratitis, interface haze, scarring, and suboptimal BCVA and suboptimal UCVA. So treatment of microstriae is required only when they are visually significant, and usually if we give it adequate time and treat with lubricants, the epithelium usually masks for the irregularity caused by microstriae. So take-home message would be flap striae are more common in early postoperative period. Dilate the pupil during clinical examination and during surgery for better visualization. Early detection and prompt intervention in the case of visually significant macrostriae. So it may require de-epithelialization, hydration, mechanical stretching, and suturing whenever we require, depending upon the severity of this striae. Recalcitrant striae can be treated with PTK, and interface haze, scarring, diffuse lamellar keratitis, epithelial ingrowth can be sequelae. Thank you.
Nice presentation. Only thing is, early need not touch the epithelium. Early means hours. If it is one day also, you have to de-epithelize and stretch. Don't use forceps, microcell sponges, in the opposite direction. One is in the horizontal, another vertical. Nice.
Thank you.
The next, any other question? Dr. Anusha? Is there? No.
It's almost similar talk. Try to cover that.
Dr. Tityal will be talking on IOCT guided management of epithelial ingrowth.
Okay. Thank you, Chairpersons, Dr. Reddy, and the audience here. Good afternoon. We talk about refractive procedures, and I think they are the one of the most safest surgery in the eye, and very, very few complications, and those complications also can be managed. One of the rare complication can be, epithelial ingrowth in these flap-related complications, which may be, there in these cases. You just heard flap folds. Sometimes they can be, difficult to manage, and these flap folds would require a repeated manipulation. Any repeat manipulation can cause ingrowth in these patients, and it can range from 0% to 20%, depending on type of procedures also. And microkeratome blades had a higher chances of epithelial ingrowth happening. With the femtosecond laser flap making and a smile procedure, now things have decreased significantly in these cases also. And these ingrowths can be graded depending on three areas: the thickness, location, demarcation line, and the relation from the flap edge. In that way, you can divide them to various grades. If you have a grade 2 and 3, that is more significant and may require a surgical intervention. If you are grade 1, then you don't have to do anything in these cases also. So there are various ways to prevent epithelial ingrowth happening. Meticulous surgery will depend on a very nice preoperative examination. What we see in those cases: good selection, avoid patients with the ocular surface disease, treat them, then take these patients. Patient has a history of recurrent epithelial erosion, patient having a viral keratitis, patient having the adenoviral episode in these cases, or a patient has history of some epithelial defect happening. Those cases should be avoided. Intraoperatively, don't damage the epithelium in a femtosecond laser or a manual keratome assisted flap making. There also, too much of putting of anesthetic agents can also damage the epithelial attachment also. Any epithelial defect during a procedure is a high chance of epithelial ingrowth also. Repeat use of blades, if you are using a microkeratome blade, should be avoided so that epithelial ingrowth doesn't happen in these cases also. Post-op meticulous management for your patient will decrease the ingrowth happening. But one of the most important risk factor is a resurgery in your patients. Resurgery, relifting will have a higher chance of epithelial ingrowth happening in these patients also. Not every patient will require a surgical intervention. As I said, if you have a grade 1, observe that patient, see how patient does. If it is off visual center, again you can observe for some more time and assess these patients in terms of visual acuity, the aberration produced by these epithelial ingrowths, and patient symptom wise. That is very, very important. So surgically you can relift the flap, debride the epithelial ingrowth from the surface of stoma, from the underneath the flap in these cases also. Non-surgical people say you can do a YAG laser treatment for these small epithelial ingrowths. I have not done personally because it is a little difficult to understand how the epithelial cell will totally get dislodged from that area, and it might cause inflammation in these patients. So this is a surgical algorithm for patient, how you do it. There are some cases where you may require epithelial ingrowth to be managed, especially recurrent cases. Primary cases, you can simply manage them by scraping them off, maybe putting a little bit of alcohol in these cases. Recurrent cases, alcohol application is mandatory for all patients. Sometimes you can do a surface ablation to smoothen the surface in these patients also. Flap suturing is not required routinely. Only those cases, recurrent cases, where you see a fistula type of appearance, there you can do a suturing in these cases also. So this is a grade 1, very small epithelial ingrowth, and this is off visual axis. You have to just see, observe. This patient may be like this for many years. If you lift the flap, you can create more complications also. So this is one case, has a large epithelial ingrowth, larger area approaching visual axis. So this case definitely requires a surgical intervention also. So this is how we approach these patients, and this is a simple technique of visualization with IOCT microscopes. This is the epithelial ingrowth area, large one approaching here. How do we know the edge of this thing? Simple dimple pressure will highlight the edge here. You can dimple the pressure, edge is highlighted. With a Sinskey hoe, you can just open that area. Don't open too larger areas. Just go underneath that, lift with the your flap manipulator, and don't try to lift the entire flap because the ingrowth is this area. You don't have to disrupt this area. So I'll take out this area only, lift the flap, partial lift, remove this ingrowth. You can see the area here. This is a lift have been done. Proper spacing. We have not gone deeper, not come superficial. Can be managed now. This can be removed effectively by just scraping by spatula, blunt spatula there. Make sure remove smoothly, don't damage the stroma, and scrape from the underneath the flap also. After this, I'll apply alcohol for at least for a 20 to 30 seconds in this patient. Then you can use a mitomycin C in case of recurrent cases. Here I can see very smooth area here. Completely epithelial cells have been removed from the underneath surface. Subsequently deposit the flap. The major advantage of OCT on table is two. One is you can see that entire area has been taken off and a nice apposition. So this is very, very important. Clear apposition of edge is very important, and that will decrease the subsequent recurrence happening in these patients. Complete removal, use of alcohol and appropriate apposition, then putting bandage contact lens at least for 3 to 4 weeks in such cases. That will decrease the chances of recurrence happening in these patients also. So this technique has been published in IGO. This is the steps of surgery. This is one case here. I can see a large epithelial ingrowth, not very large, but it's slightly near the incision area. Again, this is a post-smile. This is only one case of mine where I had a small epithelial ingrowth. Little dimple, you can highlight the incision here. You can just open the incision with the Sinskey hook. And in this case, because it's a pocket, it's not a flap, I can re-lift it. So I'll open little bit, go with the Sinskey hook to that area. After opening with a spatula there, I can just nudge it off with a reverse Sinskey hook. As you do a DSEC procedure for a decimal scoring, this Sinskey hook will helpful to take off the entire nest from inside. Subsequently, little irrigation that will take it off for this area. So this is a technique classically can be applicable for a post-smile epithelial ingrowth. Normally, they are there in the incision area, towards the incision area. Rarely you can have larger in the pupillary axis also. The same procedure, this is a day one post-op, and rarely cases would require suturing glue, especially recurrent cases where you have a little bit of stress. So this is how we manage these cases, and thank you for kind appreciation. Epithelial ingrowth is rare, but it can be managed effectively.
Thank you, sir, for enlightening the thing. The last speaker is there?
Yeah, she's there. Thank you, Dr. Reddy.
Apologies to the next session, Chairperson. We're running this last stop.
Can we have the slides? So very good evening to all of you. This is the last talk and we are overrunning, so I'll try to make it brief. There are no financial disclosures, so I'll be talking about intraoperative challenges in small incision lenticule extraction. So we all know that it's surgically challenging. We have seen a lot of PRK cases discussed today, a lot of LASIK. It's more challenging than either PRK or LASIK. Majority of the complications occur in the initial few cases, and lenticule dissection and extraction is the most challenging step. So suction loss occurs in the initial cases because it's a soft docking procedure which excavates rather than applanates the cornea, and there is a low pressure suction cone with a 35 millimeter pressure at the interface. So incidence may be as high as 11% for novice surgeon in the presence of especially other factors such as uncooperative patient and difficult orbital anatomy. Management depends on the stage at which the suction loss occurs. So in less than 10% of lenticule cut, you can redock and restart the procedure as if just from the beginning, from point 0. Greater than 10% of the lenticule cut is where the challenge lies, because you cannot really restart from initial point. You cannot restart in a rescue mode. You have to convert it into a surface ablation or LASIK, preferably at a later date. Lenticule side cut, cap side cut, relatively easier to manage because you can redock and repeat from the point at which the suction loss occurs after adjusting the parameters slightly as provided by various nomograms, and use the infrared light and the clear central bubble to recenter. So this is a case in which excessive movements by the patient led to suction loss after 2.81 mm of the lenticule cut had been completed. So the suction loss is during the lenticule cut. As you can see, the suction loss has started initially only, and this is challenging to maintain and surgery to manage, and surgery has to be abandoned. So it was retreated after 3 months with a large diameter LASIK flap. You have to change the position of the hinge because superiorly you have your side cut in case you progress to that stage. So this is a second case. Lenticule cut is okay, lenticule side cut is fine, the suction is about to get lost now. So during the cap cut there is a suction loss. So what you can do in these cases is you can redock and restart the procedure from the same point after decreasing the cap cut diameter by around 0.2 millimeter. So immediate redocking can be done, and you can clean the interface, and you can use the fixation green light and the central bubbles as relative indicators of maintaining the same centration as there was when you were initially trying to do the procedure. So after that, you do expect a little bit of increased adhesions because of the opaque bubble layer. Dissection will be not as smooth as in a primary cases. However, if you can complete the laser uneventfully, then more or less lenticule dissection and extraction goes on fairly well. So the subsequent dissection and extraction in this case was uneventful. So difficult lenticule dissection is the second challenge. Laser, you have suction loss, then the lenticule dissection. Either you dissect the anterior plane first as is described, and you have difficulty identifying in posterior plane just by virtue of maybe inexperience, maybe a difficult anatomy. Then you have when you dissect the posterior plane first and end up with a cap lenticular adhesion, and it can lead to a host of complications such as retained lenticule, cap tears, side cut tears, stromal damage, epithelial defect, irregular astigmatism. So meniscus sign has been identified to prevent lenticule misdissection and identify the lenticule edge. So you first delineate channels anterior and posterior, and while delineating the posterior channel, just push the lenticule slightly away from the site of cap side cut, so you end up with a meniscus shaped gap. And if this edge is above your instrument, you know that you're in the posterior plane. If it's beneath, you know you're in the anterior plane. So here you're in the posterior plane, and you can see this nice meniscus shaped edge with the frill above the instrument. So prevention of course is better than cure, but cap lenticular adhesion is going to be inevitable when you are doing smile. You will end up with a cap lenticular adhesion sooner or later. So ASOCT initially can help identify the dissection planes and diagnose cap lenticular adhesion, and then a Sinskey hook or any instrument, the reverse side of the dissector, can be used to just gently nudge off the cap lenticule from the overlying cap, find the anterior plane, and then dissect, do a lenticular excis, or just peel it off from the overlying cap. So with experience we have found that it's easier to manage. So this is a case with confirmed cap lenticular adhesion. I know I've gone wrong and dissected the posterior plane first, so I just go in with the sharp end, nudge the lenticule off from the overlying cap, delineate a small channel so I can make my dissector enter anteriorly now between the cap and the lenticule. Follow the same principles as I would have had I done the anterior dissection first and then posterior, like go opposite and dissect, leave small areas of peripheral adhesions, and then keep on dissecting as in you would do if you were going posterior later, and then just take it out. So it is going very smoothly. There is no side cut extension. It's a 2 mm side cut, and I don't even need to use a forceps to extract. So more important than panicking is just knowing which plane you have dissected first and then manage accordingly. So potential surgical nightmare if not managed properly. So we have had cap tears, side cut tears, retained lenticules, and stromal damage with difficult dissection. But if you can identify which plane you are in, the second plane, whichever it is, anterior or posterior, can be managed appropriately. A double crescentic edge separation has been described by us for management of cap lenticular adhesion, in which you can use 2 side cuts to nudge off the lenticule from the overlying cap, I'll just skip this video. We have also described a stepwise management for difficult identification of correct dissection plane and smile. Cap tears and side cut tears are a corollary of difficult dissection and will be observed in initial cases. They decrease with experience. So patient selection is important. Try to avoid thinner lenticules, they say, in the initial cases, but eventually identifying the edge is important, and the thickness of lenticule does not matter so much once you know the principles of dissection. Microscope integrated IOCT is a helpful tool. So just to sum up, initial learning curve of smile is surgically challenging. During laser application, suction loss is the most challenging complication that you encounter, and during dissection, cap lenticular adhesion and lenticule misdissection, which can lead to cap and side cut tears and retained lenticule. Prevention is better than cure. Complications will be inevitable, and timely detection and management give both the patient and surgeon a reason to smile. Thank you for a patient hearing.
Thank you. I invite all the panelists on the stage for a quick photograph, please.